Um, Question is from this one is from Stephen H. At what point in membranous nephropathy treatment should a nephrologist be offering rituximab? And is there any special language they should use to help get it approved by their insurance? So, like, for example, should they call it a life-saving treatment, or should they have to put it into some kind of emergency medicine code?
Yeah, so that's a good question. And I think we'll get into the basic treatments of membranous nephropathy in a bit, but briefly, um, in the 1980s, there was a very toxic regimen, which is still used, that involved a chemotherapeutic drug called cyclophosphamide. You alternated that with high-dose steroids for 6 months, and it works, but it's too toxic for most people. And then came along some medicines like cyclosporin and tacrolimus, which are good at getting the protein in the urine down, but they don't have as good long-term effects. And then came rituximab. So there were pilot studies around the turn of the millennium, around 2000. This is a drug that kills B cells and was first used for B cell tumors like lymphoma. And people thought, because membranous nephropathy involved B cells and antibodies that attack the kidney, that it would be a good treatment. So there were small pilot studies that worked very well, and then larger observational studies with 100 people showing that it worked very well. And it wasn't until what was called the Mentor trial out of the Mayo Clinic in Toronto that showed that rituximab was actually the superior treatment when compared to cyclosporin at putting patients into a complete remission. So that was published at least 5 or 6 years ago. I don't have the full date, but it was a big splash in the membranous nephropathy world. And it really established rituximab as the first line agent. And that's the terminology I would probably use. This is the first line treatment. It's recommended by our international glomerular disease guidelines called KDIGO, Kidney Disease Improving Global Outcomes. And the current trials that are ongoing, clinical trials in membranous nephropathy, are just using amped up versions of rituximab. So it really is the key treatment these days. And yes, insurance companies can be funny, but I've had good luck with it. I know that's not true, certainly globally, but in the United States, I think it should be. A nephrologist and patients should be able to push the insurance company to approve this, because it really is the first line treatment at this point.
Awesome. Thank you so much for that. I'm sure we'll get into a little bit more about rituximab and the usage of rituximab and pretty much when it's appropriate. So, to answer Stephen's question, at what point in your treatment regimen should rituximab be introduced? And I think the answer is it should be the leading treatment. It should be the first thing that we reach for off the shelf. Is that accurate?